So hello everyone and welcome to this fourth session of A Day With Me, where I'll be taking you through all the cases of my day. So starting with the first case, so here we have a 35-year-old female with cough, fever and backache since the past 1 week now. And this is how her chest radiograph looked like. This is actually a topogram, but this is how chest radiograph looked like. There was a segmental area of consolidation with haziness in the left lung field, and based on this, the clinician ordered a HRCT thorax. So this is the HRCT picture of this patient. This is the lung window. I'm scrolling from cranial to caudal direction. These are the axial sections where we can see in the anterior segment of the left upper lobe of the lung, there is a segmental area of consolidation with black bronchus sign or air bronchogram with surrounding ground glass opacities. Some left-sided pleural effusion is seen with fissural extension. These are the coronal sections where again we can see that area of consolidation with air bronchogram and surrounding ground glass opacities. Coming to the mediastinal window, so I'm scrolling again from cranial to caudal direction where we can see this particular area of consolidation with some enlarged lymph nodes in the mediastinum as well as in the left axillary region. Now, as we scroll down, an important finding that has to be noted here is that there is effusion along with this soft tissue density mass, which in the lung window was not very well appreciated. In the D11 paravertebral region, left paravertebral region, causing destruction of the posterior rib and the adjacent pedicle. So this is the report that I had given, a segmental area of dense consolidation with air bronchograms involving the anterior segment of the left upper lobe of the lung along with mild surrounding ground glass opacities, left-sided pleural effusion with fissural extension, few enlarged lymph nodes in the mediastinum and left axillary region. The important thing here is soft tissue density mass in the left paravertebral region at D11 level, which was actually causing destruction of the posterior rib as well as the pedicle of D11 vertebra, which I had given as a possibility of a metastatic lesion. And following up this patient, full workup was done and eventually she was diagnosed to have a gastric carcinoma in the pylorus of the stomach. So the clinician did not suspect this particular entity, and only after this lesion was discovered did he order a full workup for this patient where he could actually diagnose gastric carcinoma. So it's very important to look at the complete picture without any bias, and also should not ignore the patient's symptoms. Here she had complained of backache, which my technician actually said when he was preparing the patient for the CT scan. She was going on complaining of backache as well, and this was an important finding to be looked for in this case and reported. So coming to this next case of my day, so here we have a 50-year-old female with chronic cough, and this is the HRCT done for this patient. These are the axial sections, lung window. Again we can see subpleural fibrosis with honeycombing predominantly involving the posterobasal segments of the lung with apicobasal gradient, extensive honeycombing, interlobular septal thickening, fibrosis, bronchiectasis. The diagnosis is very clear here. It's a case of UIP. This is the report that I had given, which was classic of usual interstitial pneumonia, bilateral peripheral subpleural reticulations with ground glass opacities, honeycombing and tractional bronchiectasis, basal predominance with apicobasal gradient. Honeycombing was more predominant than the ground glass opacities, and the immediate subpleural lung parenchyma was involved. Few subcentimetric lymph nodes were also seen in the mediastinum. Coming to a companion case which I reported recently. So here we have a 50-year-old male with chronic cough, and again we have the HRCT picture of this patient, and these are the lung window axial sections where again we can see that subpleural reticulations and ground glass opacities that are seen along with interlobular septal thickening. Posterobasal region, the ground glass opacities are predominantly seen in the posterobasal regions. Subpleural reticulations, these are the coronal sections where again we can appreciate the ground glass opacities very well, along with some reticulations in the subpleural region, bilateral lung fields. So there is no honeycombing as such that is seen in this case. So So this was a case of fibrotic NSIP where there was bilateral reticulations along with ground glass opacities, basal predominance of ground glass opacities along with immediate involvement of the subpleural parenchyma was also seen, but there was no evident honeycombing that was seen. So coming to this important categorization of UIP into definite, probable, indeterminate and alternative diagnosis, an important thing to be remembered uh, is that in all these three, that is definite, probable and indeterminate, some features are very common. For example, subpleural predominance as well as a picobasal gradient is seen in all the three, along with inconsistent UIP features absent in all the three. Then how to differentiate indeterminate from definite and probable? In indeterminate, there are subtle reticulations with impression of ground glass opacities. That is early UIP pattern is seen in case of indeterminate, while in case of definite and probable, there will be somewhat heterogeneous distribution. Another important thing that we have to remember to differentiate between definite and probable is honeycombing is present in definite while it is absent in case of probable. Alternative diagnosis has a peribronchial or perilymphatic or upper mid-lung dominant disease with no apicobasal gradient, and there are dominant ground glass opacities, consolidations, nodules which do not fit into the diagnosis of UIP as such. So this is another important thing that should be looked for in any case of usual interstitial pneumonia, whether it is associated with a connective tissue disorder or whether it is idiopathic. So the important signs, radiological signs that we should look for in case of UIP pattern to suggest a connective tissue disorder, underlying connective tissue disorder as a basis of this particular entity are these important signs, that is straight edge sign, anterior upper lobe sign and exuberant honeycombing sign. Out of this is the most sensitive sign, and it suggests straight edge sign suggests that there is fibrosis isolated to the lung bases with a sharp demarcation best seen in the coronal images in the craniocaudal plane between the fibrotic lung inferiorly and the spared lung superiorly. So this is the fibrotic lung inferiorly and the spared lung superiorly, and this is the area of demarcation called the straight edge sign that is very well seen in these images. Anterior upper lobe sign is fibrosis concentrated along the anterior aspect of the upper lobes with concomitant lower lobe involvement but relative sparing. This is particularly seen in case of SLE or ankylosing spondylitis. Exuberant honeycombing is a prominent honeycomb-like cyst formation occurring more than 70% of the areas of the lung affected with fibrosis. So these are the signs that are associated with CTD associated UIP and not idiopathic pulmonary fibrosis. So coming to the next case of my day, so here we have a 40-year-old female with pain abdomen, and this is the ultrasound picture of this patient. My probe is kept in the right hypochondrium. This is the gallbladder. We can see a mild thickening in the wall along with a echogenic mass lesion, irregular mass lesion in the fundus region of the gallbladder. There is no involvement of the adjacent liver parenchyma as such that is seen. On color Doppler, there was minimal vascularity that was seen in this particular region, just suggestive of a gallbladder carcinoma. So 90% of the gallbladder carcinomas are adenocarcinomas, and the three important morphological types that we should remember are intraluminal mass, diffuse mural thickening and mass replacing the gallbladder, where most common presentation is mass replacing the gallbladder. The least common is the intraluminal mass, which is better seen on an ultrasound as compared to a CT scan. So coming to the very important question, why even in early cases of gallbladder carcinoma we see hepatic infiltration commonly? So this is a very important viva question as well. So coming to location of the gallbladder carcinoma, mostly it involves the fundus in 60% of the cases, body is involved in 30% of the cases and neck in 10% of the cases. Early hepatic infiltration is attributed to these four important points. So the first point being there is no serosa in the hepatic side of the wall. The wall does not have serosa, it doesn't have submucosa and has a single layer of muscle, hence making it thin and easily the carcinoma spreads to the adjacent liver parenchyma. Secondly, the venules and the lymphatics from the gallbladder drain directly into the liver parenchyma, adjacent liver parenchyma. And another important point that has to be remembered is the connective tissue of the gallbladder wall is actually continuous with the interlobular connective tissue of the adjacent liver parenchyma. Because of all these reasons, there is early hepatic infiltration seen in gallbladder carcinomas. So coming to our next case, so here we have a 23-year-old female with a swelling in the left supraorbital region along with headache. And this patient had gotten a CT scan done outside where it was reported as meningioma over the left sphenoid bone, and this is the MRI done for this patient now. So these are the axial sections, T1 weighted images, where we can see an isointense lesion, extraaxial isointense lesion over the left sphenoid bone. And these are the T1 post contrast images where we can see this conglomerated peripherally enhancing lesion. These are the sagittal images, T2 weighted images, where again we can see this isointense lesion over the sphenoid bone, extraaxial lesion. These are thin slice coronal images where we can see very well a dural enhancement, thick dural enhancement along with conglomerated lesions, and some other lesions are also seen in the right side in the occipital region. So these are the diffusion weighted images where we can see that there is some restriction that is seen in the main lesion. The smaller lesions were not actually seen on the axial images, they were only seen on the thin slice coronal images. And this is the area of restriction that is seen. So this was suggestive of an abscess, peripherally enhancing conglomerated abscess. So I asked for a history of tuberculosis, and she said that she was treated for TB 1 year back. So this is the report I had given: a well-defined extraaxial conglomerated ring enhancing lesion along the left lesser sphenoid bone causing compression of the adjacent frontal and the temporal lobes, and there was thickening and enhancement of the adjacent dura which was seen. The lesion appeared iso-intense to grey matter on T1 and T2 and showed restriction on DWI with reversal on ADC. So the feature was suggestive of an abscess, and considering the history, it was actually a tubercular abscess. Few ring enhancing lesions supported the diagnosis of TB because they were suggestive of granulomas. There was also a foci of blooming that was seen in the right occipital region, suggestive of calcified granuloma. So what we learned from the case is that tuberculosis has many presentations, and it is very important to ask for a history, especially when you see conglomerated ring enhancing lesions in the brain. Another important thing is that restriction is a very important criteria for diagnosis of an abscess. The stages of abscess also should be remembered, that is early cerebritis, late cerebritis, early encapsulation and late encapsulation, along with their imaging features, and some important signs of brain abscess like dual rim sign, light bulb sign are to be kept in mind while reporting or seeing any case of cerebral abscess. So coming to our next case, so here we have a 25-year-old male with severe headache, and this is the NCCT done for this patient. So he was having severe headache, and in the foramen of Monro, you can see a well-defined hyperdense lesion, which is suggestive of colloid cysts. This can also cause a severe headache, but in this case, I don't see any hydrocephalus as such. The important thing is there is hyperdensity seen along the left transverse sinus. The sinuses are very dilated and prominent, as we can see, but this is a hyperdensity that is seen along the left transverse sinus. This dilatation and hyperdensity along the left transverse sinus, that is very well appreciated. These are the sagittal sections where again we can appreciate that hyperdensity and dilated dural sinuses. So it was a case of left transverse sinus thrombosis as well as a colloid cyst in the foramen of Monro. So of course, to get a better look at the lesion, we should get an MRI done. So important reporting points in case of a colloid cyst or an MRI, which should be included, are these. So to understand this, we should actually know the management of a colloid cyst. So it is actually a stereotactic guidance can be used to aspirate the cyst, and the aspiration might fail if the content of the cyst is too viscous, which is predicted by T2 weighted images. So the reporting points are the size of the cyst, the T2 signal intensity of the cyst. If it is too low, it will be difficult to aspirate and it should be conveyed to the surgeon. the size of the ventricles, how much hydrocephalus it is causing, any variations in the cavum septum pellucidum et virgae, all these things, the presence and location of the internal cerebral veins, and any abnormal vasculature along the path of the surgical tract. So these things are to be conveyed in your report to the surgeon along with the lesion. So this is very important that we should think of the management and try to also describe the route the surgeon might take to explore that particular lesion or treat that particular lesion. Even in case of pituitary microadenomas, the transsphenoidal route has to be described very well. Any variations in the paranasal sinuses, whether the optic chiasma is prefixed, postfixed, all these things, they'll definitely help the treating surgeon, and you can treat the patient as a whole by doing this. So coming to my next case, so here we have a 50-year-old male with headache since the past 1 month now, and this is the MRI of this patient. These are the axial T1 post-contrast images where we can see a large lesion, ring-enhancing lesion, the left frontal region with disproportionate surrounding vasogenic edema, and another some few other ring-enhancing lesions, the right frontal region and temporal region. So at first look, it looks like tubercular granulomas, but in these thin sections, we can see T1 post contrast, most of the lesion is solid with central area of necrosis. There are some ring enhancing lesions that are seen, the temporal region and the frontal region, the right side, with some edema surrounding it. And these always get an MRS done whenever in doubt, which it will give a very good diagnosis. This is a normal area of the brain where NAA peak is seen. Proper NAA peak is seen, and this is a pathological area in that large lesion where you can see this large choline peak. No evident lipid lactate peak as such that is seen. Large choline peak is seen. Large choline peak that is seen with reduced NAA. It was suggestive of neoplastic etiology. And this is the report that I had given: a well-defined heterogeneously enhancing solid lesion with central non-enhancing necrotic area, which was seen in the left high frontal white matter. The lesion appeared iso-intense to gray matter on T1 and T2 and showed extensive surrounding edema. So this is very important. The lesion showed disproportionately extensive edema in the surrounding white matter, which was causing effacement of the left lateral ventricle. And there were two ring enhancing lesions that were seen in the right frontal as well as in the right temporal bone with edema surrounding it. And on MRS, there was a choline peak with reduced NAA. So the important thing that we should understand here is, first is to differentiate other ring enhancing lesions from this. So in this case, it was very well seen that it has a large solid component and a proper choline peak. Another important thing, we should not just stop at cerebral mets. Of course, the most common brain tumor is cerebral mets, and they were multiple, so definitely think of cerebral mets. But we should not stop at this. We should ourselves try to correlate clinically and think of what can the primary be based on these metastatic lesions. So a disproportionately large edema surrounding that particular lesion points towards a particular primary. So the 5 primary tumors which account for 80% of the brain metastasis include lung carcinoma, renal cell carcinoma, breast carcinoma, melanoma, and colorectal carcinoma. So out of these lesions, now coming to the very important search for the primary, certain important points that are to be kept in mind in this particular search for the primary are that certain malignancies are more susceptible to hemorrhage, which can aid in suggesting the primary. Metastases that classically hemorrhage include from the melanoma, renal cell carcinoma, choriocarcinoma, and thyroid carcinoma. But lung and breast carcinomas, which occasionally hemorrhage, should also be kept in mind as they are far more common primaries than the classically hemorrhagic tumors. The second important point that is relevant in our case is the size threshold at which metastases develop edema varies depending on the histology, with those from the GI tract developing edema even at the smallest of the diameter. So disproportionate edema that was seen in our case can be attributed to this particular reason. So based on this, I thought of a possibility of a colorectal malignancy, and surprisingly I got a CT scan done for this patient, and surprisingly the patient had a irregular thickening of the wall in the descending colon and the sigmoid region. And I informed it to the clinician, and they got a colonoscopy done, and it was proven to be colorectal malignancy. So rather than writing kindly correlate clinically, we should also try as much as possible to give a diagnosis of this particular, of any particular condition as such. So putting this search for the primary into practical use, and another important case that I had reported recently was of a CT scan of the brain of a 40-year-old female who came with severe headache. And these are the non-contrast sections, axial sections of this CT scan, scrolling from cranial to caudal direction. Here I can see the multiple hyperdense lesions are seen, variable size hyperdense lesions with extensive surrounding edema are seen in bilateral cerebral white matter, especially in the gray white matter junction. This is a large lesion causing midline shift to the right. Multiple variable size lesions. These are definitely metastatic lesions, and these were hemorrhagic mets. So asking further questions, she gave a history of malignant melanoma of the vagina. She was being treated for that. So coming to my next case, which is an ultrasound case. So this patient came with swelling in the neck along with increased sweating and palpitations since the past 2-3 weeks now. And this is the ultrasound picture of this patient, where we can see that there is diffusely enlarged thyroid gland with heterogeneous ecotexture, and on color Doppler there is increased vascularity that is seen. So this particular sign is an important sign. It's called, so thyroid inferno refers to a color Doppler appearance of the thyroid gland in case of active Graves' disease, which consists of small areas of color flow seen diffusely throughout the gland, representing increased vascularity and AV shunting. So this should definitely be done in case of any diffuse thyroid disease, to look for the vascularity. It's not a very specific sign. It can also be seen in early stages of Hashimoto's disease. So this is the next case, where we have a 30-year-old male with high-grade fever and headache, and he got an MRI done. He previously had he has a history of hemorrhage in the left temporal region, which has developed into gliosis now. But that is not our area of interest. Our area of interest in the right temporal region, where we can see hyperintensity on flare images, these axial flare images. There is a hyperintense vasogenic edema in the right temporal region. These are the T1 post-contrast images, where we can see that there is thickening of the meninges along with asymmetric meningeal enhancement of the right temporal lobe. It will be better appreciated on the coronal images. These are the T1 post-contrast coronal images, where we can see that there is asymmetric gyral and leptomeningeal enhancement, the right temporal region and the right insular region. These are the DWI images, where we can see gyriform restriction in the right temporal as well as in the right insular cortex. This hyperintensity on DWI, subtle hyperintensity was seen in the DWI images. So the diagnosis is very clear here. It's a case of meningoencephalitis. So this is a report I had given: abnormal gyriform and meningeal enhancement in bilateral temporal regions with extensive T2 and flare hyperintense vasogenic edema involving the bilateral temporal white matter, right more than left, and the right insular cortex. Subtle gyriform hyperintensity on DWI was also seen in the right temporal region with no evident blooming on GRE. Features were suggestive of meningoencephalitis. There was area of gliosis that was seen from previous hemorrhage also. So this is a companion case that I had reported recently, and this is a 30-year-old male who presented with a headache since the past 2 months now, and this is the T1 post-contrast thin coronal section of this patient, where we can see multiple dural based lesions, nodular thickening of the dura and enhancing extraaxial lesions, dural based homogeneously enhancing nodular lesions that are seen bilaterally, multiple areas. They were iso-intense to gray matter on T1 weighted images. These are the axial sections, where again we can see these dural based extraaxial multiple lesions bilaterally. So at this particular age, that is so young, to a 30-year-old male, possibility of malignancy should be the last. So I had asked for a detailed history where he gave a history of tuberculosis and was treated uh, uh, successfully with ATT. Now he has developed this headache since the past 2 months now. So I thought of a possibility of hypertrophic pachymeningitis in this case. And this is the report I had given: multifocal mass-like nodular homogeneously enhancing dural thickening overlying the left frontal, right lower frontal, right temporal, right parasylvian region, and it appeared hyperintense on T1 and hypointense on T2, and there was mild edema that was seen around the nodules in the adjacent white matter, which was suggestive of hypertrophic pachymeningitis, likely tubercular. So hypertrophic pachymeningitis are diffuse inflammatory or localized thickening of the dura, and on imaging they present as localized, multiple or diffuse enhancing dural thickening, commonly forming mass-like lesions. They can have many causes, which include idiopathic infective causes like neurosyphilis, CNS TB, bacterial meningitis. Inflammatory causes include IgG4 disease, neurosarcoidosis, Behçet's disease, and other rare causes include Rosai-Dorfman's disease as well. So this is an important entity that should be remembered while reporting a case of, because TB can present in n number of ways. So this is another important spotter case. This patient actually came for an ultrasound. She's a 60-year-old female. She came with pain abdomen, and incidentally this finding was seen, and I could not see the left kidney or the uterus in this patient, and I got a CT cut done for this patient. This is CT where we can see that there is absence of left kidney as well as the uterus, the pelvis. The sagittal sections as well, we can see that there is no uterus or the left kidney. There is no vertebral anomaly as such that is seen. So this is a spotter. Although in 60 years it is rare to find this. So it's a case of MRKH syndrome, that is Mayer-Rokitansky-Kussner syndrome, where there is congenital anomaly characterized by vaginal and uterine aplasia or agenesis, and is usually associated with a spectrum of other genitourinary tract abnormalities. The two different forms are typical form and atypical form, that is type A and type B. In type A, the syndrome is characterized by congenital absence of the uterus and upper two-thirds of the vagina with normal ovaries and fallopian tubes, while in type B, that is atypical form, the syndrome includes associated abnormalities of the ovaries and the fallopian tubes and renal anomalies. So the syndrome is often associated with alterations in the urinary and skeletal system, which include vertebral anomalies in 10% of the cases, and renal anomalies like renal agenesis, renal ectopic location of the kidney, fused kidney, renal hypoplasia, and horseshoe kidneys, which is seen in about 30 to 40% of the patients.